Hey guys, today we're gonna talk about the coagulation cascade in hematology. My test is on Wednesday. I've got lots of time to wrap my head around it, but I made some really good notes, so hopefully me just going over it kind of solidifies some things. Anyway, okay, so first of all, what is hemostasis? So hemostasis is the stopping of blood before you bleed out and keeping the blood in the vascular compartments. It also includes a balancing act as to not overclot and not over bleed. So there's a balancing act there. So to understand the whole thing, we kind of got to do some background. So primary hemostasis includes the formation of the primary platelet plug. So really, it's just a little clot that's not that stable. It's really small. And this is due to blood vessel injury, like from a needle prick. So nothing drastic like a stab wound. So in primary hemostasis, this is initiated when collagen is exposed from the vessel endothelium. So the major player in this game is platelets, and also collagen, and then von Willebrand factor to do a really good job. So in primary hemostasis, this occurs in 4 parts. So first, we're going to have vasoconstriction, which is just to tighten the blood vessel. So we don't want a whole bunch of blood going to a place where it's bleeding, right? So we tighten that blood vessel, but we don't completely cut it off because we don't want to cause occlusion, which is just stopping blood through the vessel, or cause ischemia, which just means no oxygen for the tissue area. So the next thing we need is adhesion for the platelet plug. This is where von Willebrand factor comes in. So what von Willebrand factor does is they grab the platelets and adhere them to the endothelium. So platelets can adhere on their own, but it's not as effective without the von Willebrand factor. So von Willebrand factor is like the platelets' besties who lend a strong helping hand. So the third one is activation. So activation includes platelets that change shape, and they provide a negative phospholipid surface to encourage the coagulation cascade further. And then the last one here is number 4, aggregation. So aggregation is due to the activated platelets. So collagen causes GPIIB/IIIA activation, which causes platelets to stick together, and it binds fibrinogen, and thus a ton of platelets arrive on the scene and they stick together to make a big lump, and we call that the platelet plug. But it isn't like a big clot, they're different. So the secondary hemostasis, it includes the stabilization of the platelet plug. So right now we have a little platelet plug that's not really doing too much. If you flicked it, you would bleed some more. So stabilization of the platelet plug causes thrombin to convert from fibrinogen to polymerize into fibrin. That causes a meshwork of fibrin. And then thrombin acts on factor 13 that further stabilizes it and causes a cross-link of the fibrin. So it sounds complicated. It's not that complicated. So you have a little platelet plug that's not stable, and then thrombin comes along, tells fibrinogen to make some mesh into the clot or the plug, and then thrombin also makes this wonderful factor called factor 13 stabilize it and to cross-link into the fibrin, making it much stronger. So if you don't have factor 13, you could bleed a lot or rebleed. So as it is come to be, we need a lot of factors to properly stop clotting, properly clot. So anyway, moving on. So Secondary hemostasis, there's another part to it. So the activation of the coagulation cascade is from the tissue factor. So like a major damage to the body, like a stab wound, would release tissue factor. So we have tissue factor everywhere. You get a stab wound and then it releases that tissue factor, which starts the secondary hemostasis, which means stopping of like bleeding out. And then it also leads to the formation of thrombin. So thrombin is a very important factor. It does many things. So we're talking about something super complicated here. I'm going to try and make it less complicated, but it's kind of hard not to. Okay, so there are 3 successional parts in the primary hemostasis. So number 1 is the initiation of coagulation by the tissue factor, like from stab wound or just something. So the amplification phase, after we have the tissue factor floating around, we want to amplify what's going on. So thrombin turns up the heat and it resends signals to factor 5, 8, 11, which activates factor 9. So there's a compounding effect here. So this topic is quite a complicated topic, and I'm going to try and make it as easy as I can, but for people who are in hematology and doing coagulation, it's really good to know your extrinsic and intrinsic pathway before continuing on. So the intrinsic pathway just means collagen was there in the beginning, and it's to make a primary like platelet plug, and then continue on to further make a big clot. And then the extrinsic factor is with the tissue factor. Okay, yeah, so they're a bit complicated. Okay, moving on. Propagation phase. So it means to cause to continue. So when the tissue factor and factor 7 combine, they form and activate 11 to, no, that's not right. No. Forms and activates 9. I was reading it backwards. Got to get used to reading my Roman numerals. So the complex forms and activates 9 to 9A, and then 9A now forms with 8 to make the tenase complex, which sparks up 10 to 10A. So yes, there's a jumping from extrinsic to intrinsic effect here. So like I said, there's 2 things going on: extrinsic pathway, stab wound, intrinsic, just collagen floating around, starting these coagulation cascades. Okay, so we don't want to overclot, so how do we do this? So finally, once we have our clot formed, we want some fibrinolysis to occur. Just means that we're going to start breaking down the clot. And it's initiated by tissue plasminogen factor. But how? So the tissue decides, though, and it decides when we're ready to heal and move on. So it's time to break down the clot and then let the highway of blood run full speed again. So it's monitored in 2 ways. So, because we need to have a regulator in order to decide to stop clotting. So there's 2 monitors here: plasminogen activator inhibitor. Sounds complicated. So it stops the generation of plasmin. So when plasmin's job is to break down the clot. So sometimes it gets a little confusing to describe because it's just weird. Okay. Anyway, so plasmin, the plasminogen activator inhibitor, is kind of like the cop calling the perpetrator and warning them not to commit or inhibit the crime. So we stop breaking down the clot. So this is the best way I can explain it. So it's like the cop saying, don't do that crime. So, and then we have antiplasmin. It works right on the plasmin to stop it from continuing to work, and it's kind of like the cop putting a chokehold right on the perpetrator at the scene of the crime. So we stop breaking down the clot again. So yeah. bit complicated. We need to decide when it's time to break down the clot and when it's time to stop breaking down the clot. So stopping to break down the clot is by plasminogen activator inhibitor and antiplasmin. Hope I said that all right. Like I said, or like I wrote in the caption, I'm a student. I'm trying my best to learn this. I'm still learning. Okay, let's move on to antithrombin. So let's say there's too much clotting now and we want to slow the clotting down and say thank you to the platelets on the scene. So antithrombin shows up and it stops thrombin by directly acting on it. Okay, so thrombin is a major player in the coagulation cascade to create clots, so it needs to be monitored. It's monitored by antithrombin. So anti means like against. So, okay, moving on. Heparin. So heparin's a drug a lot of people take. Interestingly enough, heparin is already in our blood vessels naturally. So it's normally found on the endothelial vessel, and it stops inappropriate clotting for us. So it's just there just so we don't randomly start clotting. Okay. So when someone has a susceptibility to thrombosis, which just means clotting, like a big clot where it's not supposed to be, or has a pulmonary embolism, which is the same thing as a clot, but it's like in the lungs, we give them heparin, and it works by attaching to antithrombin. It makes antithrombin have a shape change and then causes a super antithrombin. And it potentiates its action by 1,000 times, and so it has wicked anti-clotting mechanisms occurring. So yeah, so heparin, so you have a clotting, you got too many clots, and then you take heparin, but like don't just take heparin. You need a doctor's prescription for that. Nobody should just be randomly on heparin. It's super dangerous. Okay, so antithrombin works by inhibiting thrombin, which is 2A, and it also inhibits 12A, 11A, and 9A. And it's kiboshed, so we stop 10 from being activated. So 10A is directly inhibited by antithrombin. So it's here in the coagulation cascade that it stopped before it goes any further. So it's like slamming the brakes on the coagulation, because like we don't want to randomly clot and stop oxygen from going to the tissue and then causing necrosis of the tissue, which just means death of the tissue. So reasons for having decreased antithrombin. So nephrotic syndrome. Nephrotic syndrome is a kidney disease, and when you have a kidney disease, a lot of the time the pores in the glomerulus are way too large, and they're letting out protein out of the kidney and going into the urine filtrate, which is really bad for oncotic pressure. And people who have kidney disease normally have edema, because you need to have those proteins in the blood and fluid to make proper oncotic pressure. So oncotic pressure. Okay. Anyway, we're getting off track here. Okay. So we need a number of filtrate in the blood for the body to work right, because you have to have a concentration gradient, because water follows solutes. Anyway, in nephrotic syndrome, the pores are really large in the kidney, and so antithrombin unfortunately gets leaked out and we lose it. So then people who have nephrotic syndrome can clot a lot because thrombin isn't being regulated. And then also liver disease can have less amounts of antithrombin because factors are made in the liver. So be nice to your liver. Don't drink too much. You need your liver, okay? Anyway, DIC. So we can have a loss of antithrombin because of disseminated intravascular coagulation. I think that's the word for it. It just means when someone's been stabbed or during a pregnancy, they go into super clot mode, but then you have to super break it down too. And then they go into super clot, super break it down, super clot, super break it down. And so when that's happening, The factors in your body are getting used up, so it's obvious you will lose factors. And then all of a sudden you will not be able to clot and die. So very serious. DIC, super serious. We're going to get involved in it a little later. So let's continue on with our monitoring of our coagulation cascade. So protein C. So when thrombin touches the endothelial surface, which just endothelial just means the inside of the blood vessel, like the blood vessel is endothelial here. Okay, so when thrombin touches the endothelial surface, it reaches and finally binds with thrombomodulin. This complex activates protein C, and protein C's best bud is protein S, and they work together, so they're a cofactor. And in chemistry, that just means they help each other out. Protein C, complete with its cofactor, is now activated protein C, and it works really hard to inhibit 8 and 5. Without protein S, it's really sad and doesn't work as efficient, and it's not activated. Protein C's main job is to slow the clotting cascade. A deficiency in CRS causes thrombosis. So, and also factor V mutation. So protein C, it just pretty much tries to stop the clotting, but if you don't have it, you're going to keep clotting, right? Same thing with antithrombin. If you don't have antithrombin, you're going to keep clotting. So there's many parts in the coagulation cascade that are important in maintaining the balancing act. Okay, so have a drink of water. So clotting defects in general. So types of defects and how they present to you give you clues of what's going on, but the physician or person getting ready for the surgery should ask about family history and some questions like, do you bleed while you brush your teeth, and do you have a lot of blood in the sink, sort of thing. So if these issues started right away, that's a congenital cause. So it's like you inherited that. Bleeding issues that start later are acquired. Bleeding that stops and starts includes platelet defects. Bleeding that oozes from epithelium is a membrane defect. So epithelium is like your skin, your inside of your mouth, the pink stuff. Epithelium is pretty much everywhere. It's a connective tissue. Keeps things in place, lines blood vessels, etc. So you have like an oozing bleeding. That's membrane defect. So, skin is a membrane. Inside of your mouth is a membrane. So bleeding that ends up in the joints or soft tissue. So that's a fibrin clot defect. Okay. So reasons for thrombocytopenia. So thrombocytopenia just means you have less platelets than you should. So normally everyone should have 150 times 10 to the power of 9 platelets per liter, up to 450 times 10 to the power of 9, no greater than 1,000. But if they are, then you're going to be a super clotter. If they're under 150, then you're not going to clot enough. Okay, so reasons for thrombocytopenia. Penia just means less. Thrombocyte, thrombosis, thrombocyte, okay, platelets. They just mean platelets. So reasons. So splenic sequestration. So someone has mono, they can have an enlarged spleen. So the platelets actually live like in the spleen sometimes, but if it's really big, those platelets are going to go in there and hide and seek refuge. So it'll look like there's less platelets in you, but there's not, but still there's less circulating around, so that's bad. So it'll decrease your platelet count by 30%. So someone who has a gigantic spleen and it's about to rupture needs to have it removed, or they're going to bleed really bad, and they could go into DIC because of the intense bleeding and clotting. It's really, really bad. Some organs in the body are really bloody. So really bloody meaning like bleeding a lot. So spleen, liver, that sort of thing. So anyway, so large amount of your large spleen, decrease platelets by 30%. We have also increased destruction from antibodies attacking the platelets. So ITP, which is immune idiopathic thrombocytopenia, just means immune caused of unknown reason, causing low platelet counts. Also HIT, which is heparin-induced thrombocytopenia. We'll get there later, don't you worry. You will know what that means. So also increased consumption of the platelets and factors. So disseminated intravascular coagulation, so right, they're being used up. Yeah, also HUS, hemolytic uremic syndrome. We will talk about that soon. Decreased production, so any aplastic anemia. So anemia means not enough red blood cell, but aplastic means all cell lines. So that means white blood cells, red blood cells, platelets. They are not being made in the bone marrow. So sounds awful, it is awful. Also, alcoholism. For some reason, alcoholism causes low platelets. And PNH, which is paroxysmal nocturia hemoglobinuria. We learned about that last semester. Abnormal distribution. So they're hiding in the liver, they're hiding in the spleen, or they're stuck in a thrombosed vein. So imagine your whole leg clotted up. It's going to look like you have less platelets circulating when we do the blood test, because what we do is we draw blood and then we test that and we count it for the cells that are in there. Acquired platelet defects. So the use of aspirin. So using aspirin causes permanent damage of the platelets, but don't worry, it's only for 7 to 10 days because that's how long your platelets live. So it's not that bad. So before you go have your surgery, 7 to 10 days prior to, don't have it. Okay? Don't have that aspirin for cereals. Because I'll tell you a side story. So one summer I was really into trying natural remedies and herbs, and I was trying new things, and I ended up finding some wild herbs, and I made a nice tea out of it. It was really quite delicious. It was 3 days before my surgery to remove my tonsils, tonsillectomy. I found this really interesting plant. It's called alfalfa. See if you can see it. Anyway, it's actually like a purple flower. So I made alfalfa tea with the flowers. It was really nice. Come on, focus. Focus. Seems like I messed it up. Hopefully it'll fix itself. Anyway, yeah, so I had this tea. Had my tonsillectomy, and when I got out of the surgery, my face was completely gray. My whole body was gray. I was in shock, and turns out if you have wilted alfalfa leaves, you can stop your clotting factor. So I lost a lot of blood, and I was super weak after that. So really sucked. Okay, anyway, looks like I've completely ruined it. Come on, fix. No, it doesn't want to fix anymore. It's mad. Okay, moving on. Let's do, okay, so ibuprofen. Oh, ibuprofen and non-steroidal anti-inflammatories can do the same thing. So meloxicam, Celebrex, etc. Antiplatelet agents, I don't know why you would need that. Glanzmann thrombasthenia, which causes urine to have normal number of platelets and the look of the platelets, but they cause an aggregation problem of the platelets. We talked about aggregation, activation, and adherence earlier, so you can check that out. Bernard-Soulier syndrome causes a reduced number of platelets, but they're large, so they don't look right. So yeah, not good. Uremia, which causes an abnormal interaction with von Willebrand factor. And von Willebrand factor is the one that grabs the platelets and attaches them to the endothelium. So, right? Because platelets love von Willebrand factor. They're like besties. And then we also have the liver disease. So again, liver disease decrease coagulation factors. Random causes of platelet disorders. So primary purpura, which is caused by coughing or sneezing too hard and making a bruise. It's not so bad. Valsalva. So Valsalva is forcing air, but having nowhere for it to leave. So if you just do that, you can get this random purpura, so it's like a bruise. And holding your nose and trying to push air out, or blow a balloon, or straining on the toilet for some reason and holding your breath. Okay, I don't know about that. Anyway, secondary purpura. So this is caused by something else that leads to something else because it's secondary. So like an infection or allergies. So those aren't as important because the main deal that we're talking about is the coagulation cascade. Okay, false platelet counts. So in the lab, when we're looking at platelet numbers and you notice that it's a low, you get a low platelet count, and you look at the alert and it tells you that the platelet numbers might be out of whack, and you need to have an optical look at it. So it's just another way of looking at the platelets. It's more expensive in the lab, so they can quantify them. But there's also a few reasons for this abnormal alert. So platelet satellitism. So that means the platelets are surrounding a white blood cell. That's because the antibodies are against EDTA, which is an anticoagulant in the tube, red or purple tube. So, and it causes this little satellitism. So you can also have platelet clumps because you didn't invert your tube for the anticoagulant. So if you ever go and get your blood work done, there's anticoagulants in the tubes that it doesn't clot right away, which we'll get into the reasons why you want to do anticoagulants in the tube. Okay, so when somebody has an antibody to the EDTA, we recollect in a sodium citrate tube, invert and retest for the platelets, and multiply the platelets by 1.1 because of the dilutional effect, so we can get the proper results and report that out instead. So most common deficiencies are caused by either multiple deficiencies or a single deficiency. So a multiple deficiency of coagulation factors include liver disease, since all the factors are made in liver except for tissue factor. And then vitamin K deficiency, since many factors rely on it for their main function. So 9, 7, 2, and 10. Rely on that. So vitamin K is in both extrinsic and intrinsic, but mostly in the extrinsic pathway. So vitamin K deficiencies we can detect with the PT test, INR test. So we will talk about that in a bit. Okay, so warfarin is an antagonist to vitamin K, right? So it's an antagonist to vitamin K reduction, which is required for 9, 10, 7, and 2, which, so we need to continuously monitor this with the INR time, which is just another way of saying PT test. And we need to monitor this because if someone has too much warfarin, they can end up having a lot of bleeding complications. So INR means international normalized ratio. So weird stuff going on in the science world. The PT test, it's like so weird. One of the reagents includes rabbit brain. So rabbit brain in every rabbit is not the same. So we need to use the INR, which includes an ISI number, which is specific for the rabbit brain reagent that we use. So sorry to burst your guys' bubble. It's animal stuff. I'm sorry. Okay, so the INR, so we have to make sure that the number we report out makes sense because of the different concentration of the reagent. Reagent just means chemical that we use. So we have this fancy equation, which is PT time for the patient divided by PT time of normal patients multiplied to logarithmic number of the ISI, which makes a universal equation of a ratio that everybody understands in the science world. So normal INR is 0.9 to 1.3. And normal PT time, I don't actually know the normal PT time because we always do the INR. So I know about the INR. Okay, anyway, PT time just means prothrombin time and how long it takes for the extrinsic pathway to clot. Okay, we will, you know what else, if I can explain that a little better. Yeah, I think I'm gonna go there. I'm gonna jump and teach you about that really quickly. If I can find it. Okay, I'll do it off the top of my head and we'll get more in depth later. So PT, so what we do is we take a sodium citrate tube and we take the person's blood. So it's a tube with a blue lid. And we take the person's blood and there's an anticoagulant in there. So it keeps the blood from clotting. It also chelates calcium, which means it ties up the calcium. Calcium is needed for regular coagulation. So in our body. So we eat, we get this calcium, and it helps us to start the coagulation cascade whenever we need it. So by putting it into the tube, sodium citrate tube, which is an anticoagulant, plus calcium is chelated, which is binded, we are stopping the coagulation from starting. So for the PT extrinsic INR test, we are going to have this anticoagulated blood, and then we're going to add thromboplastin, which is another word for tissue factor, into there, and calcium. And then we'll start a timer and see how long it takes to clot. So that's how your fancy PT test on your Life Labs is done. So by doing that, we're monitoring for factor 7. So tissue factor activates factor 7, which goes on to activate 10, 5, 2, and 1, and then boom, we have a clot. So that's the extrinsic PT INR situation. The intrinsic with the collagen is done by the PTT test. And that's done in seconds. We don't have to worry about any ISI number on there and rabbit brains. So that starts off with the contact factors. Also, collagen has to be released from the tissue endothelium. And then we can start factor 12, which hits off to factor 11, which hits off to factor 9, which hits off to factor 8, which hits the common pathway, which is 10, 5, 2, and 1. So for the PT test, to control that, we also use the sodium citrate tube with the anticoagulant with the calcium that binds the calcium. So then we will add different stuff to it to kick it off, right? Because you want to control the test. You want to add different things to activate that pathway, because that pathway is activated by one of two ways, extrinsic or intrinsic. So the PTT, we're going to add kaolin, silica, calcium chloride, and phospholipid substitute. So then we'll start the timer when we add those things. So I hope that clears a few things up. Okay, so here we go. In depth. So we're going to do another common cause of, I feel like I've lost my place. It counts. I think I did. Okay, so we talked about warfarin, which is an antagonist to vitamin K. So we need to monitor that by the INR time, which just converts the PT time to the INR, which is normalized ratio, which everybody can understand. All people across the world understand ratio. Also, we can have common deficiencies and multiple deficiencies caused by DIC. We went over that a little bit. And then a single deficiency, which just means one factor is deficient, and that could be, usually it's a hereditary cause, Most common is the von Willebrand disease. Or we can have an inhibitor, and an inhibitor of the coagulation cascade is just on its own thing, and we'll get there. So factor VIII is in the intrinsic pathway. So when you get poked by a needle, like it's a small little thing, we're going to do the intrinsic factor, versus extrinsic factor is when you get a stab wound and then tissue factor is floating around. So right now we're just talking about factor VIII from the intrinsic pathway. So there's two deficiencies that are associated with factor VIII, but they're very different in terms of what occurs. So factor VIII is a factor, but von Willebrand factor stabilizes it and is a carrier portion of it. So it's actually together with factor VIII plus von Willebrand factor is called antihemolytic factor. And without von Willebrand factor attached to it, the liver clears it rapidly, so there's less of it. Okay, so von Willebrand disease occurs in three ways. And it's caused by, and it will cause an increased PTT and coagulation time and increased bleeding. So the first one of von Willebrand disease is a decrease in von Willebrand factor caused by one inherited allele. So parents both branch off one gene, so one parent sent off one allele, and the child inherited that one, and then also inherited a healthy one. So it's affected slightly. So this causes a decrease in von Willebrand factor. Then we also have an abnormal von Willebrand factor caused by an inherited of one allele from one parent and a healthy one, but this will cause a normal or decreased level. So first of all, we said that there's three options. So one person inherited a decreased amount of von Willebrand factor. Second one is abnormal von Willebrand factor. And third one is complete loss of von Willebrand factor. There's none of it there. And that is caused by inheriting it from both parents. So that causes major bleeding, a lot of bleeding. Even though we said von Willebrand factor or factor VIII is on the intrinsic side, the extrinsic side can reach over and start the intrinsic side, and that's why having a deficient factor VIII is bad. Okay, so von Willebrand disease affects both primary and secondary hemostasis, and to test for this deficiency or abnormality, we want to do a Ristosin test or a von Willebrand factor antigen test. We can also do mixing studies, etc. But we'll get on to there a little later. So we're going to keep talking about factor VIII deficiency. So as we said earlier, factor VIII plus von Willebrand factor causes antihemolytic factor. So when we have a factor VIII deficiency, just it on its own can cause hemophilia A. So hemophilia A is an acquired sex-linked recessive disease. So a mom is a carrier, but she passes it on to her sons only. This disorder stops the ability to clot, and it can be from mild to severe. So hemophilia, right? A lot of bleeding. So 10 to 15% of hemophiliacs have a factor VIII inhibitor. So sex-linked recessive means, so mom, okay, I have to think about this. So mom has X and X gene, and then the male, the father, has X and Y gene, because males only have one X and a Y. So a mom can have two X's. So if she inherits this hemophilia gene, because she has two X's, she's not affected because it's recessive. I hope that makes sense. It means it's not strong. The other X will dominate over it. But she's going to have a daughter, and the daughter can be a carrier or not, because the daughter will inherit one X from dad and one X from mom, because the daughters are girls and get two X's. But if the mom has a boy, now it doesn't happen all the time, the boy only inherits one X. So if she sends off the bad X, he's going to have hemophilia. Okay, so hemophilia B is caused by a factor 9 deficient or factor 11 deficiency. I'm getting my Roman numerals mixed up. So same thing, more bleeding, also sex-linked recessive, so they're inherited on the X genes. And then hemophilia C is a factor, I think 12 deficiency or 11. Oh, now that one's 11. Sorry, that's 11. Still getting this mixed up. And this is most common in Jewish communities. Okay, so inhibitors. So inhibitors can be caused by drugs or antibodies. The more common inhibitor is the lupus anticoagulant. It's more common than factor 12 deficiency. So lupus anticoagulant and factor 12 deficiency both lead to thrombosis, too much clotting. But on their PTT test, they look like it's prolonged for the clotting time. So they do the same thing, but 12 is more rare. Also, we can have the G2021A mutation, which also causes thromboembolism. The lupus inhibitor causes an increased PTT, but it causes thrombosis more. So it's due to, okay, so sorry, I'm just saying this like you guys understand it. Lupus inhibitor, it doesn't mean SLE, like system lupus something. It's not, doesn't mean cancer. It's a misnomer. Okay, so it's not related. Sometimes scientists name things when they think it's one thing, but it's not. Okay, so it could be due to an antibody binding to the endothelial and grabbing the platelets as they go by. So they're just getting grabbed, and then they start making a clot. So the lupus inhibitor is made by antibodies, either it could be IgA, IgG, or IgM, and they are phospholipid binding proteins. So people who have the lupus inhibitor can have increased fetal loss if they're pregnant and thrombosis. So factor 8 inhibitor. So the lupus inhibitor is a non-specific inhibitor because it's not really saying I'm going to do this to this specific factor and mess it up. But factor 8 inhibitor is specific, and it's an IgG antibody that attacks factor 8, and this causes severe bleeding, right? Because of, hemophilia. And it's the most common of all the inhibitors. And the second one is lupus inhibitor, and then the last one is a deficiency of factor 12 causing thrombosis. Okay, so pregnant women can have factor 8 inhibitor, and also the elderly, so causes increased bleeding risk. So testing for the inhibitors. So for factor 8, so if there was a prolongation in the PTT, we have to do a mixing study. So what a mixing study is adding one part of the patient plasma to one part of pooled plasma. So the coagulation factors live in the plasma. So when you have a tube of blood, this is going to be the red blood cells, and this is going to be plasma after we spin it down at super high speed, like vortexing, like centrifugation. It's pretty cool, and it sends the heavier red blood cells down to the bottom and the liquid portion on the top. And the liquid portion on the top contains platelets. They're small and they're light, and the coagulation factors, which are the lightest of them all. Okay, so we do a test on the patient plasma, and we find that the PTT is prolonged. So we do a mixing study with a 1 part plasma, patient's plasma, 1 part pooled plasma. So what we're looking for here is a deficiency. So what's going to happen is if there is a deficiency, the patient pooled plasma, it just means a bunch of patients mix their plasmas together, like in a tube, like not in some, okay, they're in a tube, and if it corrects, it means the patient's pooled plasma gave the factor that was missing. Okay, so if it did correct, then it was due to a deficiency, and the pooled plasma just gave up that extra factor. But if it doesn't correct, it's due to a strong inhibitor. So a strong inhibitor obviously inhibits the factor. So if you get this incorrection, you have to incubate it and retest it with the mixing study. So over time, the PTT is more prolonged if it is a time-dependent inhibitor. So let's say, first of all, it was prolonged. So normally it should be between 35 and 45 seconds. Let's say we have a 50-second one, and we're like, that didn't fix with the mixing study. It should have gone back to 35 to 45, but it didn't. So we're going to incubate this for 2 hours. And then if it further prolongs, that means time-dependent inhibitor continued to work and continue to prolong that PTT time. So prolonged PTT and PTT, we're going to just talk about it a little bit more. So if you get a prolonged PT and PTT time, then you could have a fibrinogen deficiency or multiple deficiency or the use of warfarin. So do a mixing study. So if they both correct, then it was caused by a multiple factor deficiency, usually caused by liver disease, or a common factor deficiency, which is where the extrinsic and intrinsic pathway meet in the middle to complete the task. So, okay, so there's that. So if they did not correct, if both of them did not correct, then do a TT test, because it could be hypofibrinogenemia, which just means there's not enough fibrinogen in the common pathway to make the test go right. So do the TT, so the thrombin time. So the TT, if it's out of range, then we can suspect a large amount of heparin contamination. So if the sodium citrate tube was drawn, but they had an IV line that was filled with heparin in the tube, then everything's going to be out of whack. Okay, so, or, because you want to do the thrombin time test, because you could detect that it didn't correct, and it could be due to hypofibrinogenemia, which means not enough fibrinogen. So now you got to rule those things out. So the next thing you're going to do is you're going to do a fibrinogen level. So you're going to test the level of fibrinogen in the tube. So if it isn't high enough, then you know it's that, right? Not enough fibrinogen. Okay, now only one is prolonged, PT or PTT. So if you have one PT or PTT prolonged, and you did the mixing study, and if either of them did correct, then you had a deficiency. But if it didn't, then you could suspect an inhibitor in the PTT or PT line. So then we're going to do an incubation on it, right, to see if it's a time-dependent inhibitor, which is usually factor 8. So you will need to quantify the inhibitor. So let's say, yes, we had a prolonged PTT, let's say. So now we're going to have to quantify that inhibitor. So we're going to do the BASTA inhibitor assay. So we're going to, it includes a dilution of the patient plasma, and so we're going to dilute it. And the inhibitor will be diluted out, and then it should correct, because the inhibitor should be so overwhelmed with dilution that the PTT would correct. So this test needs to be controlled. So we're going to also run it with pooled plasma with normal dilutions and run it at the same time. So, but if you suspect that it's your lupus anticoagulant that's inhibiting, then do the Russell-Viper test. I don't know much about it. It was a one-liner in our learning, so I'm just going to leave it at that. So, handling the specimen. First, I'll have a drink first. Handling the specimen. For the PTT, so the intrinsic pathway, the factor 8 and I have to get my Roman numerals right, 5 are the least stable. So we can only test them within 4 hours. So keep them at room temperature, test them within 4 hours. If you can't do that test ASAP, store it in the fridge for no longer than 24 hours. For the PT test, it actually has factor 7, which is the most stable, so it can be kept at room temperature for 24 hours, but it can't go in the fridge because the cold activates it to start the clotting. So you don't want to start the clotting so you can time it properly and see what's going on, right? Because if it's clotted ahead of time, what are you going to test? So, what happens if you have an abnormal result for the PT or PT test? So what you're going to do is you're going to rerun the test, like all things in the lab. If it's not right, rerun it again, because what if it was a random error? So we run it again. If it's still abnormal, then we go to the mixing study to see if it was a deficiency or an inhibitor. And after you do this test, you're going to store the plasma as platelet poor plasma and put it in the freezer, because you know, we may not be able to do some tests in the lab that are more specific for like a deficiency of some sort. It needs more complicated testing. So we have to store it for future testing, because you can't just let it sit at room temperature and it'll start going all crazy after a while. So store it in the freezer at minus 20 degrees Celsius. But it has to be stored as platelet poor plasma, because if we take the plasma with platelets in it and freeze it, they're going to die and they're going to explode and release phospholipids. And the phospholipids are what kicks off the coagulation cascade. So if you release those phospholipids from the platelets, then the test later won't work because it will already have clotted. So we do platelet poor plasma. So how we get that is we centrifuge the tube. So we spin it down really fast. We take an aliquot of it out of the tube. So we just aspirate some out, put it in another tube, spin it down again, repeat that process, spin it down, take some out, and then there should be no platelets because the platelets will go to the bottom of the tube. So it's platelet poor, and we also have to label it to say that, yes, we manipulated the sample, because if someone wants to test something out later onto it, the results aren't going to make any sense because the sample has been manipulated. So we got to label that. Okay, so normal ranges. So the INR normally is 0.9 to 1.3. So next time you do your Life Labs work, you can check it out. But if someone's on warfarin, it's going to be prolonged, and it's normal for it to be between 2 and 3. A critical INR rate is greater than 4. So what this means is it's taking longer to clot. So if it takes longer to clot, you have an increased risk of bleeding. But people who clot a lot will need some other medication, so they'll be on warfarin. So those levels are different for people who are taking like therapeutic drugs. Okay, so the PTT time should be between 35 and 45 seconds, but if someone's on heparin therapy, it can go up to 120 seconds for that to be normal for that patient. For a patient not on heparin, a critical range is actually greater than 60 seconds to clot. So a normal thrombin time is between 12 and 18 seconds. Okay, so what happens if someone's hematocrit is greater than 55%? So hematocrit just means red blood cells to plasma. So should look like this. But if it's like this, right? That could be due to someone who is super buff and exercising and has amazing hemoglobin and has really good red blood cells and less plasma. Or it could be due to dehydration. So there's not enough liquid in the body, so there's less plasma, etc. So what happens when that happens? So because the sodium citrate tube has an amount of anticoagulant in it, it's made for hematocrits 55 and less. But if it's a hematocrit greater than 55, there's going to be way too much anticoagulant in the plasma. So when we run the test, the PTT and PT time will be prolonged because the anticoagulant is really working hard at making it not clot. So we'd also have to add extra calcium to it to kick it off. So we, as lab techs, we need to know how to properly fill the tube and what could go wrong and the reasons why things are wrong. So there's that. Okay, so how do we do these tests and why are we talking about calcium? So normally in the body, platelets, collagen, and tissue factor and calcium would help to make the coagulation happen. We want to control this in vitro, just means out of the body, so we can know how long the coagulation factors take to work. This is how we can see what's going on. So first we tie up the calcium present in the tube so it can't work from the sodium citrate. And next, we want to remove the platelets so we don't start it up. Sorry, I'm getting a notification. It's confusing me. Okay, moving on. So the PTT test uses platelets that are removed, right? Because the platelets, we don't want them there making coagulation. So we remove the platelets out and we add silica, selite, choline, or allergic acids, which are cofactors, plus phospholipid substitute, which is the main ingredient along with calcium for that to start it all off. And then once we add those, we'll start the timer. And then we stop the timer when we see a clot forming. In the PT test, we also use the sodium citrate tube, which chelates and binds the calcium to remove it so that we can add the calcium again. And we add thromboplastin, which is just another word for tissue factor. So now let's talk about some drugs. So aspirin works by permanently stopping the production of thromboxane A2, which is responsible for platelet aggregation. So no TXA2, no aggregation. So no formation of the primary platelet plug. Heparin. Heparin works by amplifying antithrombin by 1,000 times. Thus, it's a very strong anticoagulant and it's monitored by the PTT time intrinsic pathway. So we spin the tube within an hour to prevent the neutralization of the clotting factors, and heparin should be monitored every 6 hours since it's such a strong anticoagulant. So for that one, it's for the high molecular weight heparin, so we need to monitor that. But the low molecular weight heparin is not as serious, so we don't monitor that every 6 hours. So to monitor heparin, the best test to see how well a patient's doing on it is the 10A chromogenic assay. Now, I don't know much about it. I just know that I have to know it. So I'm just knowing that one and not understanding it, leaving it at that. Coumadin and warfarin, so they're the same thing. I'm pretty sure it's the same as rat poisoning. Okay, so coumadin and warfarin ingredient is the same as rat poisoning, okay? So it stops by destroying vitamin K, and vitamin K is required for the cofactors for the coagulation cascade. So it takes 24 to 48 hours for this medicine to work. So we do need to monitor them, and so we'll monitor them with the PT test, INR test. So let's say someone's having too much warfarin, the way to fix it is to give them like vitamin K. It's and also we can, if we need to stop this warfarin like immediately, then we can give them prothrombin cell concentrate. So just a ton of prothrombin to get the clotting cascade going. Okay, so also ROGAM. ROGAM is a trick for the body. So let's say the body's making antibodies to coagulation factors. We will give the patient ROGAM, which is an antibody in itself. It's a passive antibody, so it doesn't stick around all the time, but it tricks the body into thinking that it made the antibody to attack itself when it actually didn't, and it doesn't destroy the factors. So it's like a tricking mechanism. And then niastase. So if someone's bleeding too much to DIC or something else, and we need to like hit them with some intense clotting, we will give them niastase, and it works ASAP. So like on Grey's Anatomy or some show when there's profuse bleeding like all over the place, a puddle of blood, just stick some niastase in there. Don't actually do it, let the doctor do it. Okay, DIC. So disseminated intravascular coagulation. I hope I'm saying that right. So this is caused by increased clotting and the degeneration of clots. So it increases the PT time and the PT time, but it also decreases the platelets because they're being used up along with the coagulations. So at the end of it, you end up with no clotting factors or platelets. It's pretty horrible. So give them that diastase. But in the beginning from DIC, so let's say someone's pregnant and they're bleeding out, there's bleeding a lot, but they're also clotting a lot. So it's a really interesting balancing act. So we'll give them some heparin so they stop clotting, but then at a certain point, we're going to need them to clot, so you give them the diastase. Okay, HIT, H-I-T-T, heparin-induced thrombocytopenia. So heparin has been given to the patient, but the person doesn't like the heparin and it creates an antibody to it. So the antibody is created against the heparin, but is redirected towards its own platelets, and it's a really quite miraculous formation of events. So this HIT with the heparin, patient makes antibody to heparin, but it actually goes towards the platelets, so we have a decrease in platelets. So first, in the beginning, it causes thrombosis, deep clots, but then after a while, it causes excessive bleeding because of the platelet consumption. So discontinue heparin immediately. Hemolytic uremic syndrome caused by E. coli 0157H7 attacks the kidney and starts clotting in the kidney. And it increases in uremic toxins because the kidney is responsible for filtering out uremic toxins, and it causes the destruction of the red blood cells along with occlusion in the vessels from the platelets being activated in the kidney, and it also causes the red blood cells to tear apart as they pass through the tight vessel, and so this causes a decreased amount of platelets. So thrombosis can be caused by iron deficiency anemia. So I guess now we're just talking about some random diseases, so disease states. So thrombosis, iron deficiency anemia. When someone has anemia, the kidney will start producing EPO because it will detect not as much oxygen, and the EPO is responsible for letting out red blood cells in the bone marrow. Also, it will increase in TPO, which just means that it's a hormone to start thrombocytes being released from the bone marrow. So you have iron deficiency anemia, the body's going to try and fix it, and so it'll send out TPO and EPO, and so we're going to have a lot of platelets, so that causes thrombosis. Drugs and also acute hemorrhage. Somehow a hemorrhage causes a like thrombosis, I guess, to that area, right? You're bleeding a lot, and then you just see some clotted red blood just sitting there. Makes sense. Okay, obstructive jaundice. So what's happening here is the bile duct from the liver is being obstructed it inhibits bile from entering the small intestine, and bile is responsible for breaking down food and allowing vitamin K to be absorbed. So if we have obstructive jaundice, then the bile cannot get there. Ultimately, we won't absorb the vitamin K. So it will increase the INR because vitamin K is mostly affecting the INR because of factor 7 and a couple factors in the common pathway. So treatment of the factor deficiency. So if we have a factor 7 deficiency, give them Octaplex or frozen plasma or vitamin K, depends on what's going on. Hemophilia A, we're going to give them cogenate. ATE sounds like 8 because hemophilia is from decreased factor 8. Hemophilia B, we can give them plasma concentrate, and hemophilia C, give them factor 11, and factor 10, give them frozen plasma or vitamin K. Let's see if I remember all that on Wednesday. So direct 10A inhibitors and indirectin A inhibitors. So directin A inhibitors means that they don't require antithrombin to stop the coagulation with it. But you know what? We're going to stop here because I haven't studied that much on that. So we're just going to leave it there. And I hope I made a lot of sense to everyone and that you could follow along. And thank you for tuning in. And it's perfect time. It's 9 o'clock. We should shut it down for the night. Have a great night, guys. Thank you for watching.